Tuberculosis, a disease often shortened to TB, is a significant global health concern that every nursing student must understand. It is a contagious infection caused by a specific type of bacterium. It can affect any part of the body, but its primary target is the lungs, pulmonary tuberculosis. The germ responsible is Mycobacterium tuberculosis. Understanding its behavior is the first step in learning how to fight it. Grasping the fundamentals of TB is not just an academic exercise, it is a critical competency for providing safe and effective patient care. It is also a topic frequently tested on the NCLEX. Transmission is a key concept to master. It does not spread through touch, it does not spread by sharing food. Instead, TB travels through the air. Special N95 style masks, negative pressure isolation rooms, differentiate infection from active disease, an important student pitfall. When a person inhales airborne droplets containing Mycobacterium tuberculosis, the bacteria embark on a journey deep into the respiratory system. They travel down the airways and settle in the alveoli. This initial event marks the beginning of the primary infection. Once in the alveoli, the bacteria begin to multiply. The body's immune system quickly recognizes these invaders and mounts a defense. Specialized white blood cells called macrophages engulf the bacteria, but the TB bacterium is a formidable foe. It has a waxy outer coat that allows it to survive and even multiply inside the macrophages. In response, the immune system escalates, recruiting more cells that surround infected macrophages, forming a tubercle, a granuloma. For most healthy people, this granuloma contains the bacteria. They are walled off and become dormant, latent TB infection. Active TB develops when containment fails, shortly after infection with weak immunity, or years later when immunity declines. Bacteria break free, multiply, destroy lung tissue, and create cavities visible on chest X-ray. This is when patients become symptomatic and contagious, expelling bacteria through coughing. TB can disseminate via blood or lymphatics to lymph nodes, pleura, bones and joints, especially the spine, Pott's disease, kidneys, and even the brain, causing meningitis. Understanding this spread is crucial for recognizing TB's varied presentations. The sole cause of tuberculosis is the bacterium Mycobacterium tuberculosis, not a virus, not a fungus, not a parasite. It is exclusively bacterial. Transmission is airborne via droplet nuclei. This requires prolonged or close contact with someone who has infectious active pulmonary TB. Casual brief contact is unlikely to transmit TB. Risk rises with duration, proximity, and enclosed, poorly ventilated spaces. Crowded congregate settings, shelters, correctional facilities, long-term care are higher risk. Public health screening often targets these environments. Immune status is the most important risk for progression from latent to active disease. Co-infection with HIV increases risk up to 30-fold. Other risks include diabetes, chronic kidney disease, certain cancers, and malnutrition. Healthcare workers face occupational exposure. Lifestyle risks include smoking and substance abuse. Take a thorough history, living situation, comorbidities, occupation, and social habits to guide screening and diagnosis. Diagnosing tuberculosis requires a multi-step approach. As a nurse, you must know each component: initial screening, tuberculin skin test, TST, and the interferon gamma release assay, IgRA blood test. For TST, inject PPD intradermally on the forearm. Ensure return in 48 to 72 hours for reading. Interpret the size of induration, not redness. IgRAs measure immune response in blood, require one visit, and are not affected by prior BCG vaccination. NCLEX high yield. Positive TST or IgRA indicates infection, not active disease. Further testing is required to distinguish latent from active TB. Next step for positive screen or compatible symptoms: chest X-ray. Suggestive signs include infiltrates, cavitary lesions, and upper lobe predominance. X-ray is crucial but not definitive. Definitive diagnosis for active pulmonary TB is microbiologic testing of sputum. AFB smear provides rapid preliminary results. Culture is most accurate but slow. Final results can take weeks. NAATs detect TB DNA within hours and can check for common drug resistance. Active pulmonary TB is often insidious. Symptoms develop gradually and can be mistaken for milder illness. Hallmark, persistent cough for 3 weeks or longer. Initially dry, often progressing to productive. A classic NCLEX keyword, hemoptysis. Coughing up blood-streaked sputum from erosion of lung vessels. Chronic cough plus hemoptysis warrants immediate TB evaluation. Systemic signs, low-grade afternoon fevers, drenching night sweats, unexplained weight loss, profound fatigue, malaise, anorexia. Extrapulmonary TB includes Pott's disease of the spine, TB meningitis, and renal TB. Spinal TB can cause severe back pain and leg weakness or paralysis with cord compression. TB meningitis, headache, fever, stiff neck, altered mental status. Renal TB, dysuria and hematuria. Pulmonary and extrapulmonary disease can coexist. In older adults and severely immunocompromised patients, signs can be muted. Maintain a high index of suspicion. Without proper diagnosis and treatment, TB can cause severe, permanent, even fatal complications. Unchecked multiplication leads to larger cavities and fibrotic scarring, reducing lung capacity. Chronic respiratory insufficiency impairs daily life. Miliary TB, hematogenous spread with countless tiny nodules, a medical emergency with high mortality. Multiple organs may be seeded simultaneously. Even with treatment, TB meningitis can leave neurological damage, hearing loss, vision problems, seizures, paralysis, and cognitive deficits. Spinal TB may cause vertebral collapse, kyphotic deformity, and irreversible paraplegia. Drug-resistant TB emerges when therapy is incomplete or incorrect. MDR TB and XDR TB are harder, longer, and more toxic to treat. These forms are costly with poorer outcomes, underscoring the need for early accurate treatment. The cornerstone of managing active drug-susceptible TB is a prolonged course of combination antibiotics. Standard initial regimen, RIPE, rifampin, isoniazid, pyrazinamide, ethambutol. Multiple drugs improve kill and prevent resistance. Intensive phase 2 months with all 4 drugs. Continuation phase typically isoniazid and rifampin. Total standard duration is at least 6 months. Complete the full course even if feeling better. Stopping early risks, failure and resistance. Directly observed therapy, DOT, is standard to ensure adherence, prevent resistance, monitor side effects and provide support. Monitor for adverse reactions. Hepatotoxicity is the most serious shared risk. Isoniazid, rifampin, pyrazinamide. Teach patients to report jaundice, dark urine, abdominal pain, nausea and vomiting immediately. Ethambutol can cause optic neuritis, report vision or color changes. Isoniazid may cause peripheral neuropathy. Prevent with pyridoxine, vitamin B6. Effective client teaching is paramount for cure and for preventing spread. The single most important message, strict medication adherence for the entire duration. Stopping early lets strong bacteria survive and become drug resistant. Frame adherence as a commitment to health and family. During initial weeks until non-infectious. Maximize ventilation and sleep in a separate room if possible. Cover mouth and nose with a tissue. Dispose in a sealed bag and wash hands after coughing. Wear a standard surgical mask when around people. Provide a simple written list. Report yellow skin or eyes, dark urine, vision changes, or numbness, tingling in hands or feet. Encourage a nutritious diet and avoid alcohol to reduce liver risk. Attend all follow-ups for sputum testing and ensure close contacts are tested. With consistent treatment, TB is curable. Your care team will support you throughout. For the NCLEX, distill TB into core, high-yield facts. First, TB is airborne. Initiate airborne precautions immediately and use a private negative pressure room. Staff wear fit, tested, N95 is. Second, positive TST or IGRA indicates infection, not active disease. Next steps, chest X-ray and sputum analysis. Sputum culture is the gold standard. Third, memorize RIPE, rifampin, isoniazid, pyrazinamide, ethambutol. No key side effects. Rifampin, orange-red body fluids, isoniazid, hepatotoxicity and neuropathy. Give vitamin B6. Ethambutol, ocular toxicity, pyrazinamide, hepatotoxicity. Recognize symptoms, persistent cough, low-grade fever, night sweats, unexplained weight loss. Identify high-risk groups, individuals with HIV, people in congregate settings, and healthcare workers. Use DOT to ensure adherence. Focus on airborne precautions, diagnostic meaning, ripe and side effects, and adherence, and you will be ready for TB questions with confidence.